Hi everyone, welcome to this another session on the upper limb. Hello everyone again, and I'm Dr. Ankit, and welcome to our anatomy session of upper limb. So here we'll be discussing about the upper limb, and the last topic that we did in the upper limb was the topic of arm. So we will move today towards the distal part of the upper limb, that is the region of forearm. Hi, welcome. So this is the part 2 of arm and forearm, and this sort of lectures are beneficial for or are mainly intended for university prof exams and also the NEET PG, the next exams candidates. You can use the code also below, Dr. Ankit 20 for discounts and subscriptions. Let's see those other slides. So here are some of the questions or type of questions or the language of questions that can be asked from the topics that we are discussing today. So long essay, short essays, and short answer type questions that can come from this topic. Okay, now why to choose Auricle? These are all the benefits of Auricle. We have recorded live classes, practical sessions, exam modules, and hard copy book sets. These are all the features of it. Finally, you have the practice sessions also, and these are the mainly the 4 categories of the subscriptions which are available, from foundation plan to advanced learning plan, complete learning, as well as the ultimate MBBS. The main difference is basically on the duration. So ranging from 3 months to 6 months to 12 months to around 4 years. And here are all the features plus the price package which they carry. And you can, to avail some discounts, you can use the code as well, right? Okay, so let's come to the topic. So topic, as we discussed, was basically on the arm and forearm. So let me come to the topic right now, or just a quick revision of what we have done till now. Okay, so this will give you a sort of good idea that how the things are going and where have we actually reached. So as I said that in the previous session, we discussed the topic of arm. Okay, that discuss the topic of arm, which was from the region of shoulder to the elbow. So it had 2 compartments. We discussed the anterior posterior compartment, the muscles, the nerve, and the important structures that are passing. Today we'll be discussing the forearm, which goes from the region of elbow to the region of the wrist. Okay, again, it will have 2 compartments. One, obviously, the anterior compartment, also known as the flexor compartment, and the other will be the posterior compartment, that is known as the extensor compartment. Okay, these are the basics that we need to know before rushing on to the topic. And mind you that the anterior, the flexor compartment, and posterior or extensor, in this region of forearm, whatever muscles we will see, majority or most of them are basically we can say they take origin from this area, that is around the elbow, and they pass through the wrist joint and they insert themselves, or their tendons insert into the bones of the hand. It means that what I'm trying to say is that when we say the terms like flexors or extensors, they are mostly acting on which joint? On the wrist joint, mostly on wrist and the joints of hand and all that. Suppose I'm flexing my finger, so in this position, the wrist joint is not acting. This will be the flexion of the wrist, and this will be the flexion of fingers. But the flexion of fingers is also done by the anterior forearm muscles. And if I extend the wrist, or if I extend the fingers, then again the extension of the wrist or the extension of the fingers, that is done by the muscles in the posterior compartment of the forearm. Okay, so that is why the posterior compartment is known as the extensor compartment, and anterior compartment of the forearm is known as the flexor compartment. That is one story. There will be a lot of muscles, and because as you will see and as you feel, you might feel also that muscles over here are grouped into many layers. So here we can say that the muscles are in the form of a different layer system. So we can simply write it as the muscles are multi-layered. So the muscle, suppose there are 2 muscles, right? If I give you an example, suppose this is a forearm bone, or let us make 2 rectangles over here showing us the 2 bones of the forearm, radius and ulna. Right now, the muscle which is actually close to the bone over here, supposedly this muscle over here, if I just make it some green color and label it as A muscle, okay, which is close to the bone. This will be one muscle, and suppose we make one more muscle, and here we say, okay, this muscle is a bit away, a bit away from the bone over here. Let us call it as muscle B. So out of these two muscles A and B, which one will be labeled as a deep muscle and which will be labeled as a superficial muscle? I guess we all must be knowing that this muscle A, which is close to the bone, that will be the deeper muscle compared to muscle B, that is a bit away or it is sitting over A, so that will be labeled as a superficial group of muscles. That is what actually we mean by the multi-layered muscle. The last thing before moving ahead to the main topic is that when we look at the name of the muscle, so naming of the muscles is not that complicated. We all have seen in the general anatomy that the flexor muscles will be obviously named by the prefix known as flexor something, like for example flexor digitorum. So when the word comes like flexor digitorum, you know we are dealing with the flexor of the digits like this. This is the flexion of digit. Okay, then there can be flexor digitorum profundus or flexor digitorum superficialis. So we all must be knowing that the profundus is a deeper muscle and superficialis, as the name suggests, is a superficial muscle. Okay, so naming is not that tough. But last point is about their nerve supply, because we know that the nerves are actually the we can simply make an analogy by nerves are like the electric wires which are actually lighting up the bulb or the electrical appliances in your home. So here is the muscle, so nerves over here. And nerves, mind you, that if you talk of the extensor compartment, posterior or extensor compartment, they are all supplied by the radial nerve or its branches. Radial nerve or its branches, simple as that. If we come to the anterior or the flexor compartment of the forearm, their nerve supply is mainly median nerve. Mainly which nerve? Median nerve. But a few of the muscles, not many, but a few, or we can say 10-20% of the muscles will be also be supplied by the ulnar nerve. Simple as that. But major nerve in the anterior compartment is median nerve, major. And the only nerve present in the posterior compartment is the radial nerve or its branches. Mainly its branches, which nerve? Pin. What is pin over here? Posterior interosseous nerve. So pin over here refers to the posterior interosseous nerve. Just telling you the names. Now, last thing is, sir, which will be the blood supply? So let's revise the nerve supply. Anterior compartment, mainly median nerve and a bit of ulnar nerve, supplying all these flexor muscles. The posterior or the extensor compartment, the only nerve is radial nerve or its branch, that is a posterior interosseous nerve. Now coming to the blood supply, which artery will be there? There's only one artery that is coming from the trunk, that is the axillary artery. Then in the arm, the axillary artery became brachial artery. And as it crosses the arm, the brachial artery divides into radial and ulnar artery. These are the main two arteries that is going to supply all the tissues in the forearm. That's the whole story in a nutshell. Okay. I guess now I've just briefly told you about what you are going to witness. And now let's come and see at the notes over here. Before going to the our forearm region, let me just give you a brief idea about the cubital fossa, because that cubital fossa as a topic, it comes a lot in your theory as well as practical exams. What is cubital fossa? It is in front of the elbow. This concavity in front of the elbow over here, this region over here, that is the region of cubital fossa. Okay, let us see a bit of cubital fossa and then we'll come to the major parts of it. Okay, all right, just a second. Oh yeah, over here. So we have this cubital fossa over here, cubital fossa over here. As I told you, it's a concavity or a depression in front of the region of elbow. Now, why is that important? We have done it a couple of times. Like, let me remind you that there was a lecture, there was a topic when we discussed about the superficial veins. In that, there was a median cubital vein. At that time also, we discussed a bit of the cubital fossa. But today, let's go into dig into deep over here. The normal question that will come about, it will be about the total anatomy of the cubital fossa. So they will ask you, oh, what are the boundaries of it? What forms the roof? By roof we mean the structures which are close to the skin. The floor will be meant by the structures which are close to the bone, that is more deeper. So roof is basically superficial structures or superficial relations, and floor will be the relations which are lying deeper, or the structures which are lying deeper. The deepest most is obviously the bone. So structure attached to bone, that will be the floor. Content will be structures between roof and floor. Okay. and therefore it is the importance of the contents only that this region has gained its importance, because if there would have been no content, then uh, anatomically or clinically it won't have made such a big news or big topic. It won't have become such a big topic because it's obviously the importance of the contents or the structures which are lying in the roof or the floor, right? Okay, so cubital fossa introduction is a triangular hollow situated. Let me highlight important points over. Is a triangular hollow situated in front of the elbow. That obviously you just slightly flex your elbow and see a gap over here. That is cubital fossa. What will be the boundaries? The boundaries will basically the muscles. Now these muscles you don't see from the outside, but once you're into the dissection, once you remove the skin and the fascia, then you start to see the muscles. So laterally we have the brachioradialis and medially we have the pointer teres. Remember it. And whenever, let me tell you, whenever the question of the cubital fossa comes, you start to make diagrams. And simply, as I've told it a multiple number of times before also, that in anatomy, diagrams are as important as writing theory, right? So suppose the top question comes of cubital fossa in theory exam and you draw the diagram, simply you have to elaborate whatever you have drawn in the diagram. That is the theory part, nothing rocket science over here. Okay, so base, what's base? So see, what will happen is, suppose I'm trying to make a cubital fossa over here. Suppose this is the lateral side, that is the medial side. Okay, so let me try. So here laterally you will have a muscle that is known as the brachioradialis. So the muscle is coming around like this, brachioradialis. I'm writing B and R over here. And the medial aspect, in the medial aspect, you have another muscle that is coming out, that is a PT, pronator teres. Okay, so this is the lateral border of the cubital fossa, that is the medial border of cubital fossa. But now it's a triangle area, right? So we have to form a base also over here. So this line will be a base. Okay, and it's actually an imaginary line. So base is formed by what? Base is formed by the imaginary line joining the two epicondyles, that you can actually palpate the two epicondyles. So this is actually the range or the extent of the cubital fossa. It is only this area which will be known as the cubital fossa. So remember, this is the CFS cubital fossa. So base is this. So opposite to base, this area will be what? This area will be the apex. Apex, you can see it is directed downwards, formed by the meeting point of lateral medial boundaries. This you will actually we are discussing the topic over here, and you better make diagrams of it. Fine, but ultimately, once you see it in the dissection hall, or you do the dissection on your own, that is why we have dissection hall in our anatomy departments for the first year. So once you do it and witness it and see it with your own bare eyes, it is at that moment that there generates a connection between you and the topic, and then the grasping obviously increases. So these are the boundaries. Now let's see what is there in the roof. So what is there in the roof? Roof is basically with the skin, but is there any of the structure close to the skin? Think about it. There will be obviously a couple of structures which will obviously be close to the skin. What will be that? There will be some of the superficial veins, or there can be some of the cutaneous nerves, because obviously we have a sensation on the skin. These two things. Here, more important is the superficial vein, and which vein is that? That is a median cubital vein. We have discussed in detail that it is the most commonly used vein for IV access, intravenous access. So roof will have skin, will have superficial fascia, having the superficial vein. So here you don't have the basilic, or you don't have the brachial vein. Okay, the brachial vein is a vein which is a deeper vein. You will have superficial veins only. Then you have deep fascia and you have bicipital aponeurosis. So bicipital aponeurosis also is, we have done in the arm topic that we have a muscle known as biceps brachii. Now that muscle biceps brachii, if you recall, its tendon went where? Into the radial tuberosity. Okay, but it spread out a bicipital aponeurosis going towards the medial side. This was the bicipital aponeurosis, over which was the presence of this median cubital vein. So it was basically the median cubital vein which was actually glued or stuck to the bicipital aponeurosis. Therefore, it is one of the most commonly used vein for IV access. Okay, so you can see that in the roof, this is very important area or clinical use. And let's see the floor. Floor, there are a couple of muscles which are deeper muscles. So you can see the muscle over here, brachialis as well as supinator. Supinator, where will you study? In the extensor compartment of forearm. And brachialis we have already seen where in the anterior compartment of arm. So if you remember, then out of brachialis and biceps, which muscle was the deeper muscle? It was this brachialis because it is closer to the bone. Therefore, it is forming the floor that is closer to the bone, as we have discussed over here also, that the base will be over here, the bound is over here, and the roof part will be closer to the skin, and the floor part will be closer to where? Closer to the, a little deeper to the, or closer to the bone over here. So here we have this floor. Now comes, this is the what we are trying to make. This region is the cubital fossa. So we have, it is which side of the upper limb? Is it left or right side? Think about it. You're seeing the pointer teres over here. So this is the medial aspect. This will be the lateral aspect. So we're looking at a anterior view of the left cubital fossa, left side. That's also important, right? This area is the cubital fossa. These are the boundaries. Fair enough. Contents. Now, contents you can remember with this mnemonic over here, that is MBBR. But do remember that we are going from medial to lateral, lateral to medial. That is very, very important. So M for medianer, and we are basically going from medial side to the lateral side. MBBR. What is MBBR? M is for the median nerve. So most medially in the cubital fossa, we have the median nerve. You can't palpate it, it was a bit deeper over here, and it has no pulsation, so you can't palpate it. But lateral to the median nerve, you have the brachial artery. So this you can palpate, as I guess I told you in a couple of lectures before, that how important it is to palpate the brachial artery, because this is one of the most commonly used arteries if you try to calculate the blood pressure and all. So brachial artery, then lateral to it, you have the biceps brachia. This also you can actually feel easily, very, very easily. And more laterally, or the most laterally, you have the radial nerve over here. So radial nerve, some of you might be thinking that's a radial nerve we have studied in arm. That radial nerve, let me write over here, was where? Was in the posterior aspect. Remember? And where in the posterior aspect? So it was running in the radial fossa. Yes, sir. Now we remember, yes, in the humerus behind, in the posterior aspect of humerus, we had a radial, not radial fossa, but a radial groove. My mistake, radial groove or spiral groove, right? So radial nerve was traveling in the radial groove. Now you're seeing anteriorly, yes. As it reaches the lower end of the humerus, this radial nerve will spiral around the lateral border of the humerus and will try to come anteriorly in the lateral aspect of the cubital fossa. So remember MBBR, M for median nerve, B for brachial artery, then B for biceps, and R for the radial nerve. This is very important content, and we should have the images also of it. Yes, here we have. Here we have the images. This is so many times asked in your university prof exams, both in theory, practicals, dissection. Forget about first passing up, even after passing first year. We have this as one of the most commonly asked topics in your MCQ, PG exams, NEET PG or next nowadays, or INI or name it. Okay. So here you should know that we have the middle side and lateral side, and even the image-based questions have come from the dissected images. Okay. So you can see the median nerve over here. Then you have the brachial artery, and related to it will be have brachial vein, but not that important. But then you have this huge biceps tendon, a very tough, you can just feel it. And then you have this radial nerve. This radial nerve, let me tell you, once you open up the cubital fossa in dissection, you will easily see the biceps tendon. Then you will see this brachial artery, white color. And if you dig bit, then you can easily see the median nerve also. But I have many times experienced myself, and for the students also, that it is not straightforward, easy to look for radial nerve if you don't know about it. Why? Because remember that which muscle was present over here. If I try to draw something over here, which muscle was present over here? It is brachioradialis. So basically, to look out for radial nerve, you have to do what? You have to actually retract the brachioradialis muscle a bit laterally. So once you retract the brachioradialis muscle, then is when you start to see the radial nerve. So as it is always said, and quite a famous proverb, that eyes only see what the mind knows. Let me write over here for you guys. Eyes only see what the mind knows. So if you have no idea that you will find a radial nerve also in the cubital fossa, you will not be looking for it. Okay, therefore it is always said, first make your mind powerful by the knowledge, and then seek out the whatever you have read. That is the benefit of anatomy, because here in gross anatomy particularly we see things. Same for histology as well. Okay, so this cubital fossa are very important. Clinical anatomy, fire, I guess we have already discussed it. We have the median cubital vein for IV, brachial artery for BP. For obviously fractures of the elbow, you have to deal with it, right? So this was the cubital fossa, and I hope this was very, very important. Before moving on to the forearm region, okay? Let me take you guys to the forearm region. Here we have the forearm as discussed with you. We have the two compartments of forearm, the anterior and the posterior compartment. Okay. Again, let me reiterate what we have discussed. Just for a second, that yes, forearm has two compartments, anterior known as flexor compartment and posterior known as extensor compartment. Clear? This anterior, the major nerve supply is the median nerve. Also, few of the muscles supplied by ulnar nerve. Posterior compartment, major nerve supply is the radial nerve or its branch, that is posterior interosseous. The muscles are present in multiple layers, so that is known as multi-layered. And most of them, their tendons will go to which region? Their tendons will go distally into the bones of the hand, can go into any of the bones of the hand, passing many of the joints. So they basically help movement of the wrist or the fingers or the small joints like metacarpal or metacarpophalangeal, all those sort of joints. Okay, this thing is clear. Let us now dig deep. So forearm extends between this region that we have understood between elbow and the wrist. Radius and ulnar are the bones, and they form the superior inferior radial ulnar joint. If I may ask you which type of joint it is, slightly off the topic, but yeah, we have done it. These radial ulnar joint, meaning superior inferior radial ulnar joints, were pivot type of synovial joints. Were pivot type of synovial joints. If you can remember it, very good. The muscles in front. When you say muscles in front, you are basically dealing with what? We're dealing with the anterior group. Okay. So muscles in front may be divided into superficial and deep groups. As I said, that their muscles are sort of multi-layered. Okay. Now there is a common flexor origin and there is also a common extensor origin. Now here I want you to do a small exercise over here so that you learn or you retain the things for a longer period of time. What is that small exercise? It's nothing complicated, very simple. See, what you need to do is just look at your forearm, anterior side of forearm, right? What is the anterior side? The side which is for the palmar aspect. This is the anterior side of forearm. Now you try to flex the wrist. Once you try to flex the wrist, feel the anterior aspect of forearm. Feel, you can do it like this also, but I will not be able to show you on the screen. Or let me just move a bit over here. You try to flex the wrist. And then feel on the anterior aspect of forearm. You will feel a tightness. You will feel a tightness. And then try to feel that tightness is more on the medial aspect or that tightness is more on the lateral aspect. The more you do, you'll realize that tightness is more on the medial aspect. Why? Because here we have the medial epicondyle. Okay. And just around the medial epicondyle, we have a common flexor origin. So most of the flexor muscles, they're originating from here. So once they originate from here, obviously, the direction of the muscle is from the medial side of the elbow towards the front of forearm. So more tightness will be felt on the medial side because from there it is the common flexor origin. So we know that. Just do it on your own hand and you'll realize it. So we have seen, okay, that common origin from where medial epicondyle. This is called the common flexor origin. As simple as that. And there are obviously multiple applied aspects to it as well. Like, for example, we all know about the Sachin Tendulkar, the great cricketer. And he had that problem, if you remember. I don't know whether you guys were even born at that time or not, but it was quite an old thing, I guess around 15, 20 years back, or maybe more than that. He had a problem known as tennis elbow. If you are interested, you can just Google it. He had a problem known as tennis elbow. Not the flexor, but his extensor origin, which is on the lateral side. So flexor origin is on the middle side. So extensor origin will be on the lateral side. So that at that area, he got the bony area and the tendon area. He got that area as inflamed. So that is known as your tennis elbow is also known as lateral epicondylitis. So lateral epicondylitis. Okay, and obviously it's rest and all that, that is what is needed. But we are discussing the medial epicondyle over here. So if there's a medial epicondylitis or inflammation in this region, that is known as the golfer's elbow. Which elbow? The golfer's elbow. Okay, so just remember for timing that, okay, this Okay, so mostly muscles take origin from the complex origin. Now, what are the main muscles over here? What are the main muscles? So let me tell you the names first of all, and then we'll come to the other picture. So first of all, the names. So muscles, if we talk of the front of forearm, forearm front or forearm, let me write flexors. Okay, we have groups, as we already said, a superficial group and a deep group. And a deep group. So superficial and deep group are two groups. Superficial group has normally around 5 muscles, and deep group will have around 3 muscles. Let us see their names. So superficial group will have 5 muscles. Best way to remember it is you just extend your elbow and then put your on the opposite hand the base of the palm onto the middle epicondyle and just spread your fingers like this. You'll see the 5 fingers going. These are the 5 muscles. The base of the palm or the base of the hand will be on the medial side, because just to show that okay, the muscles are coming from the common flexor origin, and the 5 fingers are representing the 5 tendons or 5 muscles. Okay, now superficial muscles, if we go from lateral to medial, just to remember, superficial muscles, if we go from lateral to medial, what are those superficial muscles? Most laterally we have this pronator teres. So what will it do? It will pronate, help in pronation. After pointer teres will have a muscle that is known as flexor carpi radialis. Okay, think about what will it do. It is going to flex. Carpi means it is going to carpals. Radialis means on the lateral side. So will it move the fingers? No. It is actually crossing only the elbow or the wrist joint. So it will help in flexion of the wrist only. More as we are going more medially, we have the other muscle known as a palmaris longus. Palmaris longus. So palmaris longus is actually on the palm. So it actually continues as the palmar aponeurosis. So it is a thin muscle and it continues as the palmar aponeurosis. Just for the time being, remember this. What is palmar aponeurosis? We'll see in the when we'll reach around the hand region. Then we have a muscle known as opposite of flexor carpi radialis. There will be one on the medial aspect. So that will be known as flexor carpi ulnaris. Okay, so these are the 4 muscles. But how many muscles we said initially? We have 5 muscles. So there is one muscle which is said to be in the intermediate group. So it is between superficial and deep. But yes, there's one more muscle that is known as flexor digitorum superficialis. Flexor digitorum superficialis. So as the name suggests, what will it do? It will going to flex the digits. So its tendons will go to the digits. Now in digits, they are in each finger, barring the thumb. In each of these 4 fingers, there are three bones in each of the finger, each of the phalanx. So this flexor digitorum superficialis it goes into which phalanx? Remember, it goes into the middle phalanx. It goes into the middle phalanx. Okay. These are the 5 muscles. One pointer teres, most laterally. Then, so this pointer teres, it will cause pronation. So supination pronation is done at which joint? Think about it. Supination pronation, as we are naming it a pointer teres, it is done at which joint? Is it done at the wrist joint or at the joints of hand? No, it is in between radius and ulna. Therefore, the pointer teres does not go into any of the hand bones. It goes between radius and ulna only. Okay, just try to understand. Then flexor carpi radialis, it is going to carpi, so it is crossing the wrist joint. Then palmaris longus, I told that it continues into palmar aponeurosis, so it is named as palmaris longus. Then flexor carpi ulnaris, again, it is not going to the digits, it is reaching the carpals on the ulnar side, that is on the medial side. So radialis will be over here, and flexor carpi ulnaris will be over here. Palmaris longus continues at the palmar aponeurosis. Pointer teres will be between radius and ulna only. And finally, flexor digitorum superficialis. So this will its tendons will go up till the middle phalanx of these 4 fingers. Right, then we have the deeper muscles. Deeper muscles meaning by that, as you're doing the dissection, you remove these muscles, and then you see a deeper muscle. Deeper muscle, we have names like profundus and all. We'll just write the names. We have 3 muscles lying the deeper, so total there are 8 muscles. 5 superficial, 3 deep. Deep muscles, we have flexor digitorum profundus. So profundus, whenever the term comes, it is lying deep. So what's going to do? It is going to flex the digit. It goes to which phalanx? It goes to distal phalanx. Okay. Second muscle will be flexor pollicis longus. Now, this term over here, if you're hearing it for the first time, understand when you use the term pollex, the term pollex refers to the region of thumb. So flexor pollicis longus goes to the region of the thumb. When we if we, as we are saying longus, thumb has two phalanx, a distal and a proximal phalanx. This flexor pollicis longus goes to the distal phalanx of thumb. So this movement over here, if you can see in the camera, this movement is only and only done by one tendon, that is flexor pollicis longus, because it is reaching into the distal phalanx right from here to here. The third muscle in the deeper one is pronator quadratus. Yes, we had a pointer teres, and now we are having a pronator quadratus. So what does quadratus actually mean? A quadrilateral shape. It is again lying deep, but being pronator or a supinator, it is actually going between radius and ulna only. Okay, this is the basic idea. Now, here only in this slide only, let me tell you, or let me ask you, or you might answer yourself that which was the main nerve in the flexor region? It was a median nerve. Okay, so median nerve will supply most of the muscles. But now the question comes that which out of these following 8 muscles is not supplied by the median nerve? So therefore, it is easier if you remember that which 2, 3 muscles or how many muscles are, or however muscles are there, which few muscles are supplied by the ulnar nerve, so that you know that the rest are all supplied by the median nerve. Ulnar nerve over here supplies which muscles? Logically, it will supply the muscles lying on the medial aspect. Ulna is towards the medial side, no? Therefore, if you look at all these 8 muscles, the medial muscles over here, one is flexor carpi ulnaris, completely supplied by ulnar nerve. Remember this. Okay, flexor carpi ulnaris. The other one will be the medial half of flexor digitorum profundus, which will be the medial half of F, D, and P. It means that the FDP lateral half is supplied by which nerve? By obviously median or its branch. Now there's one more catch. So if I may just, before moving to other catches and surprising you a bit, let me just highlight flexor carpi ulnaris and flexor digitorum profundus. Let me highlight it only half. So we know that this or these names are supplied to ulnar nerve. Now there's one more catch. What is that? A small catch over here. One more catch is that median nerve. Okay, let me use the pen, not the highlighter. Yeah, the median nerve actually gives off a branch that is known as anterior interosseous nerve. Anterior interosseous nerve. Okay. So here the remaining muscles. How many remaining muscles? 6.5. Why 6.5? Because ulnar nerve is supplying 1.5 muscles. One is ulnaris and half is this. So 8 minus 1.5 is 6.5. So remaining 6.5 muscles, some muscles are superficial, some muscles are lying deep. Agreed? Now median nerve gave off a branch known as anterior interosseous nerve. Now think about it and tell me that out of these two, median nerve or its branch, which by its name, do you think will be placed more deeper? Common sense question. Nothing to do with the knowledge. Obviously, you might answer that's interosseous. Why? Because it is must be close to the bone. So we are using the term osseous, right? Because bones are obviously in the center of the limb. So yes, anterior interosseous nerve lies a bit deep, correct? And therefore, whatever muscles are left over here, remaining 6.5, the muscles which are lying in the deep compartment, they should be supplied by anterior interosseous nerve. Therefore, now let me use a highlighter again, just to show you, okay, that here is the light green color anterior interosseous nerve, and we have the lateral half of FDP, then flexor pollicis longus, and pronator quadratus. These are supplied by anterior interosseous nerve. Though it is a branch of median nerve only, but still then we should know. And the remaining all of them are supplied by the main trunk. Remaining all of them are supplied by the main trunk of median. So if this is median over here, its main trunk supplies the pronator teres, flexor carpi radialis, palmaris longus, flexor digitorum superficialis, and that's it. So if I tell you in a nutshell what all is happening, if we talk of the number game, okay, then as you can see, median nerve supplies 4 muscles, 1.5 ulnar nerve, And anti-torsion supply is 2.5 muscles. Total, if you add 4, right, 2.5, 1.5, total comes around 8. That's it. 4 by the median, 2.5 by AIN, and 1.5 by Alana. Remember this simple. And these two are same because it's a branch only. Okay, that's it. Right. Okay, now let us look at the images and a bit of table over there to understand the things in bit detail. So write a short note on the superficial muscles of forearm. That can come as a question. Let us see the notes. Every muscle over here, see. Like for example, pointer teres over here, origin insertion. Origin again, common flex origin. Okay, inserts where it will not go into the bones of hand. It will go where into the mid shaft of the radius only. So it is written radius ulnar. Supplied by median nerve artery. Don't worry. Function, remember at least prominent arm. Okay, 4 points of forearm. Flexor carpi radialis. Now look at its insertion basically. Second and third metacarpal. Okay, metacarpal, or you can say the base of metacarpal close to the carpals only. What is second and third? Numbering has to be start from the thumbs. This is number 1, this is 2 and 3. These two over here, that will be second, third metacarpal bases. Here is where the flexor carpi radialis will come. Nerve supply, again, we have seen the nerve supply, median nerve, but look at its function. It is going to flex the wrist only, not the digits. And with radial extensors to abduct the wrist, stabilize, fine, stabilize. You know, should not flex the wrist. Let's see, palmaris longus again goes where? Into the palmar epinosis. It continues as a palmar epinosis. Nothing but a modification of the fascia. On the side we have seen, and it tenses the palmar fascia and flexes the wrist. So again, it is going like this. So it tenses the palmar fascia. Next, the fourth muscle, we have the flexor carpi ulnaris. Again, we know, okay, it's going where? Into the medial side. So medial, we have this pisiform bone. Remember pisiform bone we have discussed in osteology also. It is a sesamoid bone of the tendon of flexor carpi ulnaris. So pisiform bone. We should remember. Okay, the pisiform and this flexor carpi ulnaris, they are related. And going where? Into the base of fifth metacarpal. So fifth metacarpal, this first, second, third, fourth, fifth. So this is the fifth metacarpal, base is over here. So FCU going over here. Now supply, flexor carpi. Oh, now supply, here's a mistake over here. Let me just try to correct it. It's not mean nerve, it is which nerve? It is ulnar. Remember. Okay, it will also flex the wrist. Finally, we have the fifth superficialis. Again, it's going to all the 4 digits except the thumb. So here you have this origin coming from the epicondyle, and yeah, it has an ulnar head also. So origin is a big origin because it's a big muscle. So we have origin from the ulna also. Inserts where? Into the 4 tendons through the carpal tunnel that will see fingers 2 to 5. Fingers 2 to 5 means that except the thumb, because finger 1 is thumb. 2, 3, 4, 5. So it's going to 4 fingers. Where does the tendon insert? Let me highlight it because questions have come. Middle phalanx, as I already discussed. Okay. And again, nerve supply is the same, and strong flexor of wrist also in fingers. Why is a wrist? Because it is passing wrist also. But here, a small catch, and that can be asked as a question, that not the distal interphalangeal joint. What does it mean? That is also a question. See over here, let me try to draw and then we'll show you. These are the 3 phalanx of your, say, index finger. Okay, 3 phalanx, and that is a metacarpal. Okay. Now, if we start to name the joints, this is metacarpophalangeal. This is proximal interphalangeal, that is distal interphalangeal joint. If we say it is distal phalanx, it is middle phalanx, and it is proximal phalanx, it is metacarpal. Then these are the, let me underline the joints over here, the joints. Now, as you are seeing that the tendon of the FDS is going till the middle phalanx only. This is where the FDS tendon will go. So is it crossing DIP? No. So it won't flex the DIP. It will flex the PIP. It can help the MCP. It can help the wrist joint, but it is not crossing the DIP. Here you have the FDP tendon that will reach over here. So if I make this purple color and if I try to draw the FDP, so FDP tendon will reach over here. So it is the FDP that is going to flex the DIP joint. Or you can say it is only the FDP which is going to flex the DIP joint. FDS doesn't reach there. Remember this. Okay, now let's see the deeper muscles over here. 3 muscles. They see here comes the FDP over here. So where it is going to the base of terminal phalanx, as you should know, nerve supply, we have seen anterior and the ulnar nerve. So it is also regarded as a hybrid or the composite muscle, hybrid or the composite muscle. Okay, functions, we have seen that it will, now this, remember, it flexes the DIP joint, flexes the PIP also, and all these joints over here. Now, how can the examiner ask you questions in different forms from the simple information? In a next PG sort of exam or an EP sort of exam, there can be small GIF or small video known as GIF, where they may show you the movement of one of the fingers. Like for example, they may show you the movement of over here, where you can see the PIP joint is being flexed. Okay. And if they show you only the DIP being flexed over here like this, and they may ask you, okay, which muscle causes this, then you should know the answer. That if the DIP is only being flexed, it is FDP. And if the PIP is shown as flexed, then it is not only FDP, it can be FDS also very easily. Okay, second, deeper muscle is flexor pulsus longus. Now, deeper muscle, when you're saying, you should know that what we are dealing with the nerve supply is anterior interosseous nerve. When dealing with the deeper muscles, it is anterior interosseous nerve. Second is FPL. It goes into the distal phalanx of thumb. Again, anterior interosseous nerve. Okay, flexor of thumb. And when we say flexor of thumb, we don't mean this only, we mean the flexor of the interphalangeal joint of thumb as well. Here, let me write. It is flexor of thumb and also the flexor of in IP joint of thumb. Also IP joint of thumb. So do remember this. It is the only muscle that will flex the IP joint of thumb because it is only the muscle or only tendon that is crossing the IP joint of thumb anteriorly. Last but not least is the pointer quadratus, and again, as I said, it is running between radius and ulna. Because supination, pronation, movement per se are between radius and ulna. Again, being a deeper muscle supplied by which nerve? Anterior interosseous nerve. Okay, front is a forearm as the name suggests. So these are all the front of the forearm muscles. So here the five different muscles and shown with the different color coding. You can see most laterally is pointer teres. Okay, it is between radius ulna. Then we have the flexor carpi radialis over here. This tendon you can feel. And let me actually increase your knowledge a bit. This is the lateral side, that is the medial side. Okay, here just lateral to FCR, this is the where you palpate your radial artery or your patient's radial artery. So radial artery is just lateral to the tendon of FCR. This tendon is, this is what? This is FCR tendon. Remember this relation. And you have this light blue color, that will be palmaris longus over here. This is palmaris longus. And you have this. So sir, where is FDS? FDS guys is also been regarded as an intermediate growth. So whatever big muscle you're seeing below over here, now that is all FDS. Deeper muscle will be deep to all this. Some of you might be looking at a diagram and might be thinking at your own, this is also looking like a flexor. No, it is coming from the lateral aspect, remember. This is the region of the, we can say the medial epicondyle, so common flexor origin. While over here, lateral epicondyle, you have the common extensor origin. So which muscle will be this? This will be brachioradialis. Remember the cubital fossa over here? This was the cubital fossa. Okay. This is the black highlight. I'm just trying to completely make it black. That is the cubital fossa. And boundaries were between the brachioradialis and the pronator teres is yellow color. Pronator PT, pronator teres over here. Okay, so this brachioradialis is basically, we'll study that in the extensor compartment. Right? Okay, so these are all the muscles and different diagrams over here to show you the muscles over here. Just have a look at it. Some of the muscles over here. Okay, just these diagrams, but fine. Don't worry too much about it. So I guess you understood well. Okay, now let us look at the extensors of the forearm. Which muscle group? Extensor of the forearm. Before going to the extensor of forearm, I'll give you a brief idea. Okay, and then we can just dig into it a bit. Now, what is this extensor retinaculum of the wrist? In our wrist, we have a flexor retinaculum in front and extensor retinaculum behind. These retinacula are the tight modifications of the deep fascia. Okay, so these are coming from where? These are coming from the deep fascia. Let me highlight it so that you remember that they are coming from the deep fascia. Just a 2 seconds. Okay, this is the deep fascia. Color might not be working, but don't worry. Okay, so these are the retinaculum. So if you look at the retinaculum extensor over here and see what the tendons are passing beneath it, we actually know a good idea of what are all the extensor tendons. So deep fascia on the lower part of forearm forms second band known as extensor retinaculum, passes obliquely downward. And actually what happens in the case of the extensor retinaculum is that it actually sends septa and it divides the whole region deep to the extensor retinaculum into 6 compartments deep. So we have the bones, then overlapping bone, we have the extensor retinaculum. So if I show in the lateral side, this is, imagine my extensor retinaculum. So it will send septa towards the bone. So these septa actually will divide this whole region into 6 different compartments. And through these different compartments, the muscle tendons will pass. Muscle tendons will pass. So that we know that what are all the muscles which are lying over here, whose tendons are passing into the dorsum of the hand. Because once you extend your fingers, you'll see, or you can feel also a lot of tendons over here. Here you don't feel the tendons because you have a thick palmar aponeurosis and thick palmar fascia. Tendons are here also, but they're all deep, so you don't feel them easily. But here, there is no palmar fascia. Here, if you just extend, you'll feel the tendons. These harder structures, they are not bones, they are tendons. You can feel it. Once you extend, you will feel this sort of thread, not thread, but yeah, cord. These thick cord-like structures, they are not bones, they are the tendons. So once you see what are the tendons that are passing through these septa, we know what are the muscles in the extensor compartment of forearm, as simple as that. Therefore, I choose to start with the extensor retinaculum topic and then look at the muscles of the extensor compartment of forearm. So here are the muscles or the structures passing through tendons passing through the 6 septa over here. So which will be which side? Think about it. There are many hints over here. We all know that the lower end of radius is broader than the ulna. So this is the lateral aspect, that is the medial aspect. So now if I ask you what will be the numbering of the septa, the numbering always starts from the thumb side. Thumb side means lateral side. This has to be septa number 1. This has to be septa number 2. This has to be 3. This has to be 4. This has to be 5. And this has to be 6. Got the point? This is how we can easily. Now, towards the thumb side, meaning by that over here, towards the lateral side, we will have tendons whose name will be either pollicis, they are going to thumb, or their names will be radialis, because they are going laterally. Think about it. All the tendons that are towards the septa or towards the compartment 1, 2, or lateral compartments, their tendon name will either be pollicis, or it will be radialis. The tendons that are going towards the medial side, that is tendon the compartment number 5 and 6, their names will be obviously written over here, or that ulnaris. Okay. So you have carpi ulnaris over here, and you have digiti minimi means the small digit, this little digit, little finger over here. So now what is left is septa of compartment number 4. So here you have the other tendons of for the other digits like extensor digitorum tendon, extensor indicis tendon. That will. So before even starting to learn or cram, or what we normally say ratana, without knowing what you are trying to memorize, have at least a good basic common sense of what will happen, where it will happen, why it will happen. So now I didn't mention even one complete muscle name, but I just said that compartments on the lateral side, numbering 1, 2, 3, all that, they will have muscles that are going to the thumb or the radialis. Compartments towards the ulnar side, or 6th compartment like that, 5th compartment, they will be towards the ulnaris side or the little finger name. And between you will have the digital. Now you can easily see. Compartment number 1 will have extensor pollicis brevis and abductor pollicis longus, both going where to the thumb. Compartment number 2 will have a ECRL and ECRB, that is known as ECRL tendon, this is known as ECRB tendon. What will they do? Okay, think about. Let me go back to the first compartment. Extensor pollicis brevis and abductor pollicis longus. What will they do? Common sense. This is going to extend the thumb. This is going to abduct the thumb. This is extension of thumb. This is flexion of thumb. That is extension. Remember when we did in the general anatomy, the movements. This is flexion of the thumb, this is extension of the thumb. What is abduction then? This is abduction. This is abduction. Then this is adduction. Abduction is not this. This is extension. Abduction is this. So abductor pulsus longus is going to abduct the thumb. Let me put a highlighter over here. It's going to abduct the thumb. I don't know why the highlighter is not working. Maybe yeah, over here, yeah. And this is going to extend the thumb. Compartment number 2, ECRL, ECRB, extensor carpi radialis brevis and extensor carpi radialis longus. What will they do? Think about it. They are the extensor tendons. We are going to the carpals on the lateral side. Okay, so they are going to extend the wrist. Compartment number 3, again extensor pulsus longus, again going to extend the thumb. But here you have extensor pulsus brevis, and this is longus. So it's just a matter of which tendon is longer. So you can see compartment number 1, 2, 3 are related to the lateral side and the thumb as well. Simple as that. Moving to the 4th compartment, we have for the other digits. So extensor digitorum, it's going to extend the digits like this. And extensor index is going to make a separate tendon for the index finger only. Along with them, you have an artery and a nerve as well. So you have anterior interosseous artery and posterior interosseous nerve. Just remember their names. Compartment 5 and 6, what will be there? Digiti minimi and carpal Digiti minimi, little finger, and carpal itself, meaning by extend the wrist, but not going to the digits. It is at the base of the metacarpal or the carpal only. This is how you can do that. Now you know at least that what are all the muscles that will be lying where in the extensor compartment of forearm. So needless, before even going to the topic extensor compartment of forearm, we at least know all these names. These are tendon muscles that will be lying there. Now, which muscle tendon name or whichever muscle tendon name is not included over here, what can be the only reason is that that muscle will end before it crosses the wrist. There we have a couple of muscles, like for example, brachioradialis muscle. You are not seeing it over here, but it is brachioradialis. It will end the radius only. And there's also a muscle known as supinator. You're also not seeing it over here. In these compartment, you're not seeing its name. Why? Because it is supinator. So I told you in the beginning, supination pronation is a function between radius and ulna. These two you don't see. But rest of all, you're seeing over here. Try to think about it. How easy now the topic has become. So make this diagram, extensor retinaculum. Look for all the tendons. These are all present in the extensor of forearm. What is not present over here are the muscles which will end before they reach or before they cross the wrist, which are these two. Or 80% of your topic is done. We only have to see their nerve supply. Nerve supply, I already told you. It is posterior interosseous nerve. It's a branch of radial nerve. The radial nerve itself will supply, say, it might supply the brachioradialis over here. Just a second. Okay. It might supply the brachioradialis separately over here and also a bit of extensor carpi radialis longus. But all of the others are supplied mainly by the posterior interosseous nerve, which is actually nothing but a branch of radial nerve. Now let us see the muscles. Okay, these are the names of all the structures lying in the compartment. Here comes the superficial, again, like in the front of forearm, we have the back of forearm muscles. But now you have a good idea. So there are some superficial muscles on the back of forearm. They cross the elbow joint. Obviously, they will cross because they're coming from the common extensor origin again. Common extensor origin is where? On the lateral epicondyle. Remember, I'm sure you all must have seen few of the matches also. Sachin Tendulkar, quite a famous personality, Bharat Ratna awardee. He had this problem. I don't exactly remember the year, might be a couple of decades. Okay. Tennis elbow, lateral epicondylitis. Fair enough. Now, superficial muscles. Let us look. Extensor carpi radialis longus. Let me just use the highlighter over here. Extensor carpi radialis longus. So it is reaching the digits. No, it is reaching the metacarpus and the carpus. Okay, insertion. You can see over here. What will it do? Extend the wrist. Okay. Nerve supply, radial nerve. Second muscle, extensor carpi radialis brevis. A bit, a bit shorter muscle. So it goes into base of third metacarpal. Nerve supply, posterior interosseous. What will do? Sort of same function. Extend the wrist. And then extensor digitorum. extensor digitorum, extending the digits. It inserts into the extensor retinaculum, and then from the see, actually there's a whole what you say, the dorsal digital expansion over here. So there's one more term known as dorsal digital expansion over here. You see, you only feel the tendons over here. Once you move distally, you don't feel the same tendons. What I mean to say is, if you extend the fingers, you feel the tendons in behind or in the region of knuckle only. Once you are moving in the finger, now here you don't feel any tendons easily in what you can feel in the front of knuckles. Why? Because here the tendons spread out and they insert into all those phalanx. Okay. Now supply again will be, here comes the posterior introitious nerve now. Which nerve? The posterior introitious nerve. Over here. Function, it is obviously main extensor of the wrist joint, for the finger joint, not the wrist, but finger joints. But here we are using the word digitorum. So these are the three superficial muscles. Others are also here. Let us give their names. Digiti minimi, again, similar thing. Little finger, posterior introitious nerve, extensor joint, little finger, then extensor carpi ulnaris. Now, will it extend the digit? No, it will extend the wrist joint. It is going to extend the wrist over here. Okay. Ulnaris so goes to the medial side. So which metacarpal? Which metacarpal? Just like flexor carpi ulnaris. We have extensor carpi ulnaris. Sixth one over here is brachioradialis. Will it cross the wrist? No. Where does it insert into the radius? Comes from the humerus. So which joint does it cross? Does it cross wrist? No. Will it do pronation? No. Supination? No. What will it do? It slightly helps in flexion at the elbow. Flexes elbow. It is one of the rare muscles. Rewind it. Very important question over here. That though it is regarded as a muscle of the posterior compartment, and we always say extensor, extensor, extensor. But here is one exception to the posterior compartment, which is actually causing flexion in the elbow. But only small condition is that it has to be in a mid pronation position, not like this, not like this, somewhere like this. So if you look over here, this is a mid pronation position or mid supination. If you flex the elbow in this position, then this is the brachioradialis that will act over here. Okay, so do remember this. Okay, then these are all the muscles that you can see. The brachioradialis right over, let me label it brachioradialis. Then we have the ECRL and ECRB, ECRL, ECRB over here. Okay, then you have this whole extensor digitorum. This will be the extensor carpi ulnaris, and a very anconeus you've seen in the posterior arm only. This is the anconeus over here. Okay, some of these muscles, digiti minimi over here, extensor digiti minimi over here. So you can see all these muscles. Then we can also see some of the deeper muscles. What muscles are left are deeper muscles. So looking at this image and these names only, I hope you can think of what muscles are left over here. Okay, if I ask you this ECR were in which compartment? They were in compartment number 2. Okay. Extensor digitorum was in compartment number 4. Right? Okay. Extensor digiti minimi was in compartment number 5. Carpi ulnaris was in compartment number 6. Okay. We have compartment number 4, 5, 6, and 2. Which compartments are missing? 1 and 3 compartment tendons, they are missing. What was in 1 and 3 compartment tendons? Let us see over here. This is compartment 1 and number 3. So these are the thumb tendons. Some tendons going to the thumb. They are deeply placed. They are present deep. So before looking at the topic of deeper, now just by looking at superficial, we should be clear of what tendons should be there in the deeper. Okay, one is supinator also. That we missed out. Yes, that will be there. Because it is again goes to the bones only. And then we have better pulses, longest pollex. You can see all these pollex over here. Yeah, and this is also one more. You may have missed it. This was in the 4th compartment. This is. Okay, these are all the deeply placed. Supinator, let us look at a couple of things of it. Now supply will be posterior introitious nerve. So it will actually help in supination only. Abductor pulses longest, needless to say, abduct. Okay, they all will go into either the first metacarpal or the phalanx of thumb. So you can see over here, it goes into the thumb metacarpal. These extensors, they might go into where? Into the phalanx of the thumb. And as the name suggests, extensor also, so it will going to extend the joints of the thumb. Simple as that. No big things over here. Extensor indices will go and extend the index finger. Nerve supply, as we discussed, all are supplied by P, I, and S in parallel. So life becomes very easy. that you know that, okay, post-tension nerve is there, right? So these are all the muscles, guys. I am sure you guys should keep on revising it. So do revise it, make some diagrams, look at the book diagrams, look at the notes diagrams over here, and you are very good to go. You are very good to go. Okay. So, I mean, coming back, like these are all the plans. So if you enjoyed it and if you want more of these classes, log on to it, and you can use the discounts as well. That's all from my side. Thanks for watching. And these are all the social media handles that you can use. Bye bye. Good night. Take care. Any queries, let me know.